Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on self-advocacy. Medical visits often feel rushed and impersonal, leaving patients feeling shortchanged. Today, I want to talk to you about advocacy at the doctor's office, specifically self-advocacy, which can really be challenging for some people, especially those of you who struggle with anxiety. But it's important because today it's easy to fall between the cracks at a busy doctor's office if you don't self-advocate. Whatever else, preparation is crucial, whether it's your first visit with that provider or your 50th, but especially on that first visit, obviously. However, at every visit, you should know what you need to discuss beforehand and what questions you have, because with prescribers, there will be time constraints. With psychotherapy, talk therapy, you get 50 minutes. With medication checks, sometimes you're lucky to get 15. But you as the patient can be a large determining factor as to whether you get 20 minutes or 5. Some practices are busier than others, and in most, you spend more time waiting, checking in, talking to the nurse, waiting some more, and checking out and scheduling your follow-up than you do actually interacting with the provider. Factor in driving back and forth, and the time spent seems really inefficient, which is why I'm a huge fan of telepsychiatry and the concierge practice model, but those are topics for another day. You'll want to be clear about what symptoms and/or side effects are troubling you and prioritize them, not only due to time constraints, but in case there's a conflict between them. For example, treating a symptom induces a side effect, and we can't improve the side effect right away without sacrificing efficacy. So we have to decide which is more important, suppressing the symptom or reversing that side effect. The answer is not the same for every individual. It depends on the respective symptoms. We can consider the side effect a new symptom that we should add to the problem list, a new problem. And it depends on the respective severities, and it depends on the individual's preferences and lifestyle, etc. For some, weight gain or sexual dysfunction trumps a little tearfulness. We would back off of the dosage. But if we're talking about panic attacks, a lot of patients will accept a little blunting of the libido, at least temporarily. Priorities certainly shift over time, and they should be periodically reviewed. Also, most side effects improve over time on their own, and in the maintenance phase of treatment, when a person has been in remission of their illness for a few weeks or months, the dose of medicine they need to prevent a relapse is less than the dose needed in the acute phase, and we can lower it and improve chronic side effects in the process. A lot of times, we end up on a higher dose than we plan to continue taking in the long term because we were in a hurry to improve symptoms, but now we can back off a little bit. So there are multiple considerations, but prioritizing the problem list is an important step that patients often don't think to do. Also, have your questions written out. Have a list. I recently posted a video on what questions to ask your mental health provider, in which I gave 3 examples. But if you want the complete list of 62 questions and follow-up questions, a total of well over 100, leave a comment, give me the list, and I'll share a link for a free digital download in PDF. Remember, you're the patient. There are no stupid questions, period. And you can't have too many. There's no limit. Now, if you truly have way too many to be answered in a single visit, that's probably a sign that you're having anxiety. A skilled practitioner will see that and will be able to address the anxiety itself and help guide you into focusing on the important questions, the real questions. If you have a laundry list, definitely prioritize those as well. Ask yourself, what are the most important ones? Which questions directly impact my treatment now? And leave the more esoteric stuff for another day, to be more efficient in your information gathering. The list that I came up with is fairly comprehensive, but I don't mean for viewers to adopt all 62 and try to ask them during a single appointment. Those questions really are meant to spark a dialogue, to make sure you and your clinician are discussing certain topics and themes. Like all conversations, provider-patient discussions should have a life of their own. Inspire follow-up questions you didn't have written down, and even inspire your provider to ask you questions they otherwise wouldn't have addressed. I often have to ask patients additional questions in order to properly answer some questions they have for me, because we haven't discussed those things yet. When a patient asks me what we can do about sexual dysfunction, for example, I have questions. I have a host of follow-up questions that will enable me to better understand the side effect, what it is exactly, its impact and implications, so that we can prioritize it and settle on a course of action, which may be no action. We might decide that it's in the patient's best interest to be patient and wait. But usually I have to ask a bunch of questions because patients don't typically give me enough information initially. So that question list is not meant for you to get through as many as possible in rapid fire mode and settle for 1 or 2 sentence answers. The questions are a springboard. You want a dialogue with your provider. There should be a back and forth on all matters pertaining to your care and progress. Arming yourself with a question list is a good way to advocate for yourself, but it's also a good way to stay organized. Another way to self-advocate is to be assertive. Some doctors are more attentive than others, some have better bedside manner. You might not have to work as hard with those providers, but plenty are not so engaging for a number of reasons. You shouldn't feel like you're catching your doctor between patients, like they're rushing in a hurry to move on to the next exam room. A lot of clinics are set up that way, where there are multiple patients waiting in multiple rooms and the doctor's going from room to room. And if you're engaged in telehealth, make sure you're engaged. Please don't settle for those prescription factories where you spend 5 minutes and you see a different provider every time. Those aren't mental health follow-up visits, and they usually involve controlled substances. It's your time, and it needs to be sufficient to address your needs, whether that's 15 minutes or half an hour, however long it takes. But you might have to gently insist if you begin to feel rushed. Now, if the doctor has to move on, which happens, an otherwise attentive doctor has to move on to the next appointment, then ask to finish up on the phone. Or if it's a simple matter of a couple of unanswered questions, by availing yourself of your patient portal account, where you can message the treatment team. And it's okay to ask to communicate directly with your provider and not with an intermediary, a nurse or a PA, physician assistant. The attending physician, who's legally responsible to you, always has to be directly available, even if you have to ask. Now, lots of patients work with nurse practitioners and have never met the supervising doctor and have a good working relationship with those providers. I'm not denigrating those therapeutic alliances, okay? I'm not talking about those situations. I'm referring to instances in which you establish a doctor-patient relationship and then hear back from substitutes between visits, which is a common practice. That works for a lot of things, routine refill requests, etc. But I've had to request that the doctor get back to me personally, and not because I'm a physician myself, but because I met with the doctor. The doctor knows what we specifically discussed at the last visit, and the nurse practitioner doesn't, which is why I'm getting the runaround or being told that I have to make another appointment. Anytime a substitute fills in, the quality of care diminishes, ever so slightly or a lot. That's just a fact. Continuity of care is paramount. This is your care. You have a right to good care, and you're paying for it, whether it's out of pocket or a copay on top of your insurance premium. But you know what? Even if it's free, you're entitled to the same standard of care that every patient receives. You don't have to be pushy by any means. Well, hopefully not, right? If you do, you should move on to the next provider. But you can be assertive without being confrontational. If you're an introverted type who loathes confrontation and who just can't bring yourself to make tiny demands that are well within your rights as a patient, then that's a symptom that you should be discussing with your provider. You have clinically relevant interpersonal anxiety, if not outright social phobia, and it should be a focus of treatment. Once you break the ice by admitting this to your psychiatrist, it makes it easier to then take action because you simply verbalize how difficult it is for you and how you need help advocating for yourself. If you need that help, tell your provider. It makes it easier. This should then cue the provider to be extra vigilant in terms of making sure that all of your questions and concerns have been addressed at every visit, that all of your needs are being attended to. For you providers out there, recognize your timid patients and take their hand. This reluctance to impose, to quote-unquote bother the clinician, prevents patients from calling between appointments with requests or to report developments or difficulties. How many times have I heard, "I know you're really busy and I didn't want to bother you," from unassuming patients with high anxiety? Some patients will run out of medicine and wait several days because they have an appointment coming up and they, quote, "didn't want to bother me." I usually have to reassure those individuals over and over again that I want them to call me, that it's not at all an imposition, and that it bothers me more that they stop taking their medicine. So the doctor should help you in this regard if you confess it. It should be more or less obvious to the skilled practitioners. So you practitioners out there, take note, but some providers need prompting, and there's nothing wrong with that. Another way to more easily assert your needs is to bring a buffer, a family member or a close friend who can help nudge you. Not someone to speak for you, although as a last resort, I've seen that as well. I have one patient with social anxiety whose wife attends us at every visit. She does most of the talking, but it's what he needs. And we communicate well, and I always make sure that the patient gives me his opinion about what's being said. He usually, in 1 or 2 word sentences, he usually affirms that yes, that's the case, everything's accurate, what she's saying is the case. I always give him space to talk, but that's what he needs. And plus, it's always good to have a family member attend. But providers should not let family members do 100% of the talking. As a provider, you should always try to get the patient to engage you directly verbally. But maybe someone to help get certain conversations going, particularly if it affects them as well. Often family members have their own concerns, and it's perfectly valid to invite them to join your sessions. Family, and that's broadly defined, are always welcome at appointments, and fire any provider who tries to put constraints on that. What else can you do to stay on top of your treatment, to help your provider give you the best treatment they're capable of delivering? That's really the best way to conceptualize it. If you shy away from being confrontational, it doesn't have to be adversarial in the least. Don't conceptualize it that way. You're not calling them out. You're helping your provider by asking for the attention you need, by reminding them of certain aspects of your treatment, by prompting them to be thorough and to allow time for questions. I always ask, do you have any questions? But if you don't get that question yourself, you don't have to ask for permission to ask. Sometimes patients will ask me, can I ask you a question? Of course you can. I'll often start wrapping up by asking, have we talked about everything we needed to discuss today? That's better than we're out of time. And even if I can't spend another 10 minutes discussing something new because I have a patient waiting and the clinic has to run on time, we can address it on the phone or via the portal. The doctor has to be available to you between visits. That's the standard of care. And the patient portal is a great way to organize your thoughts and document your needs in writing. Those messages become a part of your record, although they're often not included when you request a copy. So if you want those, you might have to ask for them to be released to you as well. Another way to stay organized is to take notes during the visit, which a lot of patients know to do, especially if they have a tendency to forget. Here again, the presence of an ally, a family member, friend, or caregiver can be incredibly useful because not only are they there to jog your memory, but there's less chance for confusion or miscommunication. Sometimes patients mishear or misapprehend the doctor. Also, and this is important, read your prescription bottles. It's surprising how many patients don't do that. I would say most. The official instructions will be printed on the label, as well as the number of refills. So be assertive but respectful. Bring a list of written questions, not 62, save some for later. Take notes during the visit. Avail yourself of your patient portal account. Don't be afraid to ask for clarification. Read your bottles and bring an ally if you need one. That's it. Please join me for part 2. What specifically can go wrong besides rushed appointments? That includes jargon overload, dismissed symptoms, incomplete follow-up, and most importantly, lack of shared decision-making.